So the third speaker, we would like to invite Dr. Ashwaq Sahafi. She's a consultant in gastroenterology and also she is the head of gastroenterology section King Fahad General Hospital in Jeddah. She will speak about the breast feeding and gastroenterology and hepatology disorder. Dr. Ashwaq.
Thank you very much, Dr. Abid, for your kind introduction. And I would like to thank the organizing committee and everyone who had great effort on making this event successful this year. So lactating mother in GIT clinic, they rarely present to our clinic unless they have original disease related to the GIT system or liver disease. So they are originally our patients who got pregnant and currently lactating. So they are coming to the clinic inquiring some questions regarding themselves or the baby. Through this presentation, we will go through in brief, about the physiologic facts about breast milk, GIT benefits of breast milk, and some scenarios about lactating mother in GIT clinic. Breast milk is a magic formula that provides most of the protective mechanism naturally presenting in the breast milk. It gives nutritional benefits and balanced formula for the baby, providing infants with antibodies that prevent, postpone, or attenuate disease caused by pathogens in their environment. The importance of breastfeeding, there are baby-related benefits and mother-related benefits. Regarding the baby-related benefits, it prevents diarrhea, ear infection, pneumonia, and asthma. It cuts the risk of sudden infant death syndrome and lowers the risk of obesity and developing allergens. Mother-related benefits, it lessens the risk of ovarian and breast cancer. It prevents postpartum depression and type 2 diabetes. It reduces the risk of stress. The GIT benefits of breastfeeding are multiple, as the breast milk has multiple factors that affect the GIT innate immune system. For example, the oligosaccharides promote the growth of commensal bacteria in the gut. Secretory IgA coats harmful and commensal bacteria, preventing penetration to the epithelial barrier. Lactoferrin can bind iron and prevents the microorganism from using it. And it can produce multiple anti-inflammatory, it reduces the inflammatory cytokine productions. And some multiple mechanisms are found that will benefit the GI innate immune system. So before we advise the mother to stop breastfeeding, we have to clearly make sure that it is really contraindicated. The CDC, Center of Disease Control and Prevention, the absolute contraindication given by them to stop breastfeeding to the baby, from the baby side, galactosemia, which is an autosomal recessive disease associated with deficiency in an enzyme that metabolizes galactose. Mother-related factors are HIV infection, antiretroviral therapy, untreated active TB, human T-cell lymphocyte virus infection, using or dependent on illicit drugs, chemotherapy, and radiation therapy. So lactating mother will come to the GIT clinic either concerned about her baby or concerned about herself, and most of the time she will be concerned about her baby. By far, constipation. The first scenario we'll talk about is constipation, which is the most common presentation in lactating mother. Constipation is common in this group of patients because of the hormonal fluctuations and physiologic changes, pain medication used during this period for episiotomy pain control, and hydration caused by volume loss during delivery or breastfeeding. So the mother-related concerns here in constipation would be how to treat constipation, how to avoid it, and how to manage complications like hemorrhoids and fissures. And the treatment here is not different from the general population. We can treat them just as any patient presenting to the clinic, and usually they don't present to the GI clinic, to the general clinic most of the time. Baby-related concerns are the safety of laxative medication during lactation period, as they have concern whether it's excreted in the breast milk or no. Most studies show that laxative medications can be safely used during lactation, and the secretion in the breast milk is very minimal, and mainly with stimulant laxatives. The second scenario is a lactating mother with IBD in the GIT clinic. The mother-related concern here is the disease activity during this period. Baby-related concerns are disease in the offspring, medication secretion in breast milk, vaccination, and screening of the offspring. The activity during lactation of IBD, according to the ECHO guidelines, the influence of lactation on disease activity and childhood is almost negligible. Lactation does not independently affect disease activity unless the mother has stopped taking her medication during this period. So always we have to stress on the importance of continuation of medication during breastfeeding. Breast milk has some protective effect regarding IBD to the mother and the baby. Some evidence show that protective effect against disease flare in the postpartum year for the mother, and it is reported that the breastfeeding might be protective against the development of early onset IBD in the children. Regarding disease in the offspring, the risk of IBD, if one parent is affected, it's 2 to 13 times higher than the general population. If both parents affected, then the risk increases up to 30% in the offspring. Regarding the siblings of patients with Crohn's disease, they have 13 to 36 times risk of having IBD compared to general population. And in ulcerative colitis, the risk of the siblings to have ulcerative colitis is 7 to 17% higher than the general population. So if they have risk, do we need to screen them? The answer is no, because even if we screen those patients, although research for predictive markers that could identify family members at risk of IBD had been insensitive to such marker had been identified so far, even if we found marker specific for this target, doing this will not affect the disease course, as we cannot start any medication for the child before they develop the symptoms and signs of the disease. What about medication safety during lactation? In fact, fetal exposure to most IBD medication is considered low risk for the baby, except for methotrexate and thalidomide. Fetal exposure to thiopurines is not associated with increased risk of infection in the first year of life. The risk of infection with anti-TNF agents usually increased in patients who continue to take this medication through the whole pregnancy. And there are live attenuated vaccines are the major concern in this group of patients, as a case fatality has been reported in a mother who was taking anti-TNF medication through her pregnancy, and the baby developed disseminated TB post-delivery. So we have to always postpone the live attenuated vaccination until 6 months post-delivery. Or we can stop the anti-TNF medication at 24 or 26 weeks of gestation. So the take-home message in this scenario is that the role of gastroenterologist in correctly educating patients to avoid misconception is paramount. Stress on the benefits of lactation for the baby and the mother, and the clear understanding of medication safety during lactation will improve clinical management of the patient and decrease flares during postpartum period. The offspring has 2 to 13-fold increased risk to develop IBD compared to general population. There are no current data recommend screening of the offspring. The third scenario is viral hepatitis. The first one is HIV. Although HIV, IgM, has been secreted in, has been found in breast milk of infected mother, the infection was not transmitted to the baby. So no current data available to recommend against breastfeeding in HIV-infected mothers. What about HBV? According to the ACLD recommendation, HBV should not be a contraindication for breastfeeding unless the mother has cracked nipples, bleeding, or infected nipples, or has HIV co-infection. So what are the other concerns? The prophylactic treatment. Mothers will not require prophylactic treatment during lactation. They may need it during pregnancy if the viral load more than 200,000. Vaccination program for the baby. It is recommended by the CDC, and WHO that the baby, all infants born to hepatitis B surface antigen positive mothers should receive immunoglobulin prophylaxis and hepatitis B vaccination immediately after birth. What about the medication safety? For hepatitis B, antivirals are minimally excreted in breast milk and are unlikely to cause significant toxicity. And most of our patients has been taking those medications safely through lactation. But the unknown risk of low-level exposure of the infant should be discussed with the mother. Regarding hepatitis C infection, again, the ACLD does not recommend against breastfeeding unless the mother has cracked, bleeding, or infected nipples, or HIV co-infection. Regarding treatment of hepatitis C during the lactation period, the indication has to be evaluated and delayed therapy is recommended, as the DAA safety is a concern during lactation period. HCV RNA levels has been observed to be reduced, and some patient has cleared the virus during postpartum period. 25% of patients in an Egyptian study had spontaneous resolution of the virus, with especially in patients who had favorable allele of IL-28B. So we have to give those patients chance to finish their lactation period. They might clear the virus, or we can start the treatment after the mother finished the lactation time. The last scenario here is the mother with celiac disease presenting to the GIT clinic. Any mother who has child with celiac disease should not be on gluten-free diet or stop breastfeeding. A mother who has celiac disease has positive breast milk test for tissue transglutaminase IgA and IgG. So if the antibodies are secreted in the milk, does this affect transmission to the baby? This is one of the concerns from the mother, and other concerns are disease inheritance and screening of the offspring. Regarding the antibodies in breast milk, this study regarding anti-gliadin antibodies in breast milk from celiac mother on gluten-free diet, it has showed that although the antibodies are secreted in the breast milk, those children had equal conditions as non-celiac disease mother to acquire the disease. So again, having celiac disease is not a contraindication to breastfeed the baby. And the other point here is there was different trends has been observed for total IgA levels decrease markedly during lactation period in celiac disease mother compared to general population. So the IgA level, which is, we have TTG, it's an IgA, so the level is very low in lactating mother, so which is further reduce the risk of transmission to the baby. Then the other point is the risk of celiac disease in the offspring. The baby is a first-degree relative, so his chance to have celiac disease is 7.5% compared to general population. Female patients and female first-degree relatives had higher prevalence than male patients in a ratio of 1 to 7. And so when should we screen a baby born to a mother with celiac disease? Patient with first-degree family member should be tested if they show possible signs or symptoms or laboratory evidence of celiac disease. The other indication is to consider testing of asymptomatic relatives with first-degree family member who has confirmed diagnosis of celiac disease. And the take-home message here is whatever is the indication, whatever is the presentation of the mother to the GIT clinic, you don't have to stop lactation. Thank you very much.
Thank you, Dr. Ashwaq, for a great talk. Please, all speakers, be in the stage. You can take a few questions before we conclude this session.
Okay, Dr. Lou, Dr. Nahla, Dr. Ashwaq. We are running behind time, so we can just take a few questions. And there is no questions came to the app. So might take one or two questions. Dr. Lou, what do you think the question number one is about the Saudi custom dressing? You have to.
It's much warmer than I thought. So when I start talking, I have to think about how to position this. It's very great.
My question to you, how safe these medications, the prokinetics like broccolibride, linaclotide, on long term? You know, most of the studies, they give it just for a few months, then they said stop it, the patient improved, that's it. But if I continue the patients on these medications for years, is that okay?
Yeah, in my practice, it's been okay. The longest term data in clinical trial, as far as I recall, is up to 72 weeks. But then you have this phase for ongoing monitoring trial for prucalopride, by the way, has been at least in Canada for about 4 to 5 years now, as far as I recall. If it is effective, I think it will be okay to continue. There's no reasons it cannot. In the beginning, in terms of its side effect, there's some concern about cardiovascular safety because of the other prokinetic, but it's believed to be related to the non-specific channel activity rather than the 5-HT4 agonist action. So in terms of prucalopride, the major cardiovascular side effect is sinus tachycardia in healthy volunteer, but in clinical trial that really didn't pan out, even in an elderly trial. So in my opinion, prokinetic, if you use it appropriately when it's necessary, it is appropriate. In terms of linaclotide, we have it only for about 2.5, 3 years in Canada. In the States, has been available longer. It is a locally acting agent that does not really have systemic effect or absorb systemic availability or bioavailability. So I would say that it will be safe to use it long term, particularly your patients require the medication to maintain symptom-free.
Thank you for the nice presentations. My question to Dr. Nahla, I enjoyed very much her talk about the fecal transplantation, which goes in my thinking about the Crohn's disease and its relation to gut microbiota. I thought of another idea. Our gut microbiota, it will be influenced by our genes. So can we study genetic mapping of these patients who have Crohn's disease, and we compare them to other healthy people? Maybe in the future we can do gene therapy to these patients and cure their disease. Because fecal transplantation, it will be transient solution of the problem, and it will not be lifelong lasting solution. Thank you very much.
Thank you for your comment. As you rightly mentioned, that the inflammatory part of the disease has different pathway. We are treating the immune part. However, microbiota part, it is promising now. Genetic part, a lot of study now, and maybe in the future of IBD, they said that maybe we will just take blood sample from the patient, do some mapping, and then we decide his phenotype and response to treatment, and choose a treatment individual based on that. FMT with IBD, I mentioned, is promising, especially in UC rather than Crohn's. However, an RCT study, as I mentioned, it was oral abstract in UAG. It was from China. It showed promising, and if you see the graph, I would see the response within the first 2 to 3 weeks. So maybe with capsule, it helped to provide this as a route and duration of administration. A lot of unanswered question, mainly the route, duration of administration, and the impact with the long term. Thank you.
Yeah, actually maybe I will add an anecdote, which is, I thought of it after your talk, Dr. Nahla. Old people from older generation, my grandmother and her generation, they used to use the animal feces. They don't have enough resources to put for the kids diapers, so they use it as diapers, and they will say your kids always having a diaper rash and infections, while our children never had diaper rash. And they mentioned about treating abscess, putting animal feces, dried animal feces, grinded in the Niger, and they will put it, and it will heal the abscess. And I heard several, stories from older ladies. So.
I think we'll get the last question for Dr. Ashwaq. So the safety of thiopurine. So almost we discussed with the patients. Thiopurine. Amiran. Yeah. To stop the medication, to continue all over the pregnancy, after with lactation? So
Yes,
what's usually the
it is
concern?
very safe to go taking this medication through all the pregnancy and even during lactation period, as secretion in breast milk is very low and will not affect the baby or increase the risk of infection. The mother can take it safely during pregnancy and lactation. Not like they used to say before, pumping and dumping, no more.
It's-
According to my latest review, when I went through the subject this time, there was no recommendation to do pumping and dumping unless you have any idea about this. For me, I didn't go through this. Dr. Nahla? Yes, there is no clear recommendation. هنا الفيس.
I think it is expert opinion. For me also, I didn't get this pumping and dumping. And from the or pharmacokinetic of edesabrine, the maximum peak of absorption within first 4 hours. So this, it comes from that expert, they said if you overnight, take it at the night, overnight not to lactate, and early morning dump it. That means in mother or maternal circulation is it is a peak away from the baby to be transmitted through. This is, and I do recommend that to my patient.
Okay, I think we are reaching the conclusion now for this forum. So on behalf of all of the audience, I would like to thank our speakers, Dr. Lou, Dr. Nahla, and Dr. Ashwaq, for the excellent presentations. With the tight time, they stick to their time. And we can actually give now the stage to Dr. Mohammed Al-Khatami to conclude. Thank you all. Thank you.